We're going to quickly move to our next session, and we're very excited to have this today for you. It is something that is becoming more and more prevalent in treating kidney cancer, and not every place has it, but there's certainly a lot of interest, and it's one of those places where you might have to go to a cancer center in order to receive this treatment. But it is radio frequency ablation and cryoablation, and we're so pleased that Dr. Oleg Mironov has joined us today, and he's going to speak to this. Good morning, how are you?
Good morning, how are you?
Good, thank you. It's so nice of you to join us. This is a really hot topic for our kidney cancer community, and we're really excited to learn more about it. So thank you for joining us. I'll just let you know that Dr. Mironov is the lead interventional radiologist at St. Joseph Healthcare in Hamilton and an assistant professor at McMaster University. He did have his training, I believe, in New York, is that correct? And then moved to University of Toronto and to finish off, I think that's right. Yep. And your focus is treating patients with cancers of the kidney, liver, and lungs using various ablation technologies. So welcome, and we'll let you take it away. Thanks so much.
Thank you for having me. Let me just share my screen. So my topic today is going to be on the role of interventional radiology in the treatment of kidney cancer. And my name is Dr. Mironov. So I think the first thing I'd probably address with you guys is what is interventional radiology? Usually that's the first question I get asked. We're a subspecialty of diagnostic radiology that focuses on procedures. We typically perform procedures under imaging guidance, so under X-ray, ultrasound, and CAT scan, not cameras. I often get asked that. It's not endoscopy, that's a different part of medicine. Our procedures are generally minimally invasive, usually done via needle puncture. We treat a fairly diverse set of conditions and people all over the body, unified by need for imaging guidance. Our training is distinct from surgery and medicine. So we're not surgeons, formally speaking, we're not medical doctors. There is a fair amount of crossover with traditional clinical specialties, including in our training, and it's changing over time, but we are a distinct specialty. And our fundamental training is rooted in image interpretation. So that tells you a little bit about what we do. So as kidney masses are relatively common, and they can present in early and late stages. And we typically need diagnosis to optimize treatment. Now, our diagnostic colleagues will often identify these masses on CAT scans, MRIs, or sometimes ultrasounds, but definitive diagnosis requires tissue, typically a biopsy. And biopsies are needed in early cases to exclude benign kidney masses that can be observed, such as oncocytomas. Biopsies are needed in advanced cases to tailor chemotherapy regimens and for prognosis. So this is biopsies are a fairly big component of what we do. Biopsies are typically done as a day procedure at our center. Patients get conscious sedation and a local anesthetic, some freezing of the skin. And then under ultrasound or rarely CT guidance, we put a needle up to the mass and take tiny slivers of tissues about 1 millimeter in diameter, about 2 centimeters long, that are sent to pathology. There's no incision, it's a needle puncture. This is typically followed by a bit of bed rest prior to discharge. Results usually take about 1 to 2 weeks. There are some risks to the procedure, which are bleeding, infection, and injury to nearby structures. The risk of significant complications are quite low, 1 in 300 or so. And even then, they typically will resolve on their own or with some minor procedure, such as an angiogram. There was some previous concern about clinically significant tumor spread, which is not really supported by modern literature. So in our center, pretty much all kidney masses get biopsies prior to being referred to me. So what are small renal masses? With regards to ablation, we're usually talking about something called T1A disease. So these are small renal masses, smaller or equal to in size to about 4 centimeters. We usually find them during workup for something unrelated, such as trauma. So a patient might have a car accident or an episode of diverticulitis and happened to have one of these masses. The appearance on CAT scan and MRI is a small enhancing mass from the kidney, and the enhancement is relative uptake of contrast. So you get an intravenous contrast dye injected, and when looking at the CAT scan, you can see that the mass lights up. And this will be important later when we discuss follow-up. The detection and evaluation are best done with an abdominal CT or MRI with a specific imaging protocol. So it's not just any regular CT, you have to be really looking for it. It usually requires 3 phases and requires contrast. So it's pre-contrast, arterial, and venous. What is ablation? Ablation is essentially biopsy plus. So all the things that I told you about ablation about biopsy are true for ablation as well. In Ontario, kidney ablation is performed using either heating, that's radiofrequency ablation, or more recently freezing, that's cryoablation. Both are well established and have been used for over 30 years, especially in the United States and elsewhere. And ablation efficacy and safety is strongly affected by size and anatomic location. When chosen correctly, it's extremely effective when we treat the right tumor. Typically, a patient is first seen by a urologist. After a biopsy confirms cancer, they're referred to an interventional radiologist for an ablation treatment. After a consultation with an interventional radiologist to ensure that the ablation is appropriate and if the patient can tolerate it, the procedure is scheduled. One other thing I should mention is typically at our center, we discuss all our cases at a multidisciplinary rounds just to make sure that all the relevant specialties agree that this is the right choice for the patient. Usually it will involve a urologist, an interventional radiologist, a radiation oncologist, and usually medical oncology, such that the decision making is optimized for the patient. How does ablation work? Well, what is ablation? So radiofrequency ablation is you apply an alternating electric current in the 350 to 500 kilohertz range. So it's an oscillating electrical field, and it's applied to a probe where the tip is applied to the tumor. This causes an elevation in the surrounding tissues up to a lethal temperature, and the cells die by something called coagulation necrosis. They're basically burned or heated up such that they lose moisture and die. The tumor doesn't get taken out, it stays in place, but the cells are dead, so the risk of it metastasizing and causing illness is gone. Treatment ends when either an adequate temperature is reached or when there is a rise in something called impedance. Impedance is a measurement of the tissue's opposition to alternating current. That current is collected through large grounding pads on the patient's thighs. So at the beginning of the procedure, you get a pair 4 of these grounding pads on your thighs, and that collects stray currents and allows us to measure impedance. Cryoablation is a fairly different, similar but different technology. It works similarly to a refrigerator or an air conditioner. A cooled gas such as argon is cycled through a thin needle, which causes the surrounding temperature to fall. Sometimes more than 1 needle is required, 2 or 3, and this permits treatment of larger tumors. Temperature below freezing causes ice formation, which ruptures cell membranes. You can also get cell death by cooling to sufficiently low but non-freezing temperature, which will kill off cells. Pads are not necessary, there's no currents involved, and the treatments are time-based, so they're set as a timer, and that's how long the treatment goes. Some people will do direct temperature monitoring, but generally not necessary, and you could also observe the ice ball formation on a CT scanner. I should say that both of these, in order to get the needle up to where it is, it's directed under imaging, which is where we can. So what are some of the indications for ablations? We're looking at small renal masses. The optimal outcomes are really for masses that are very small, so for under 3 centimeters. We'll go up to 4 centimeters, depending on patient circumstances. really what the other thing that drives this is favorable anatomic location. So things that are more off to the side, closer to the back, or down lower are easier for us to treat. We prefer them to be kind of hanging off the kidney rather than deep in the tissue of the kidney or pushing into the inside. That has two benefits. The blood vessels are smaller, and also in the case of both ablation and cryoablation, radiofrequency ablation, you get this oven effect where, due to the surrounding insulation by fat, the temperature rises and drops more quickly. Masses that are closer to the front of the kidney are a bit more difficult to treat because there's a higher risk of bowel injury. Masses that project into the inner component of the kidney where the urine collects risk injury to the collecting system, and masses that are high on the kidney risk injury to the lung or the diaphragm. There are certain locations which will cause adjacent organ injury but are considered generally acceptable. One example is muscle, another is liver and spleen. This is more so for radiofrequency ablation, where burning a bit of the liver or the spleen is generally not very risky, and the organ will regenerate. With cryoablation, there is some more risk of bleeding, but generally still relatively acceptable. The main indication traditionally for ablation has been patients who are poor surgical candidates due to medical issues or due to patient preference, if somebody prefers to have a less invasive surgery. And as I mentioned, candidacy is typically discussed at a multidisciplinary round to make sure that everybody's on the same page. Ablation is typically done as a day procedure at our center. Patients get conscious sedation and local anesthetic, so freezing to the skin, just like for a biopsy. And then under a CAT scan or ultrasound guidance, a probe is advanced to the mass. The probe is fixed in place. There's a few different methods. You may get an additional needle puncture to inject air or fluid to push away some vital organ, typically the bowel, using D5W, which is sugar water, or maybe a little bit of gas. And then ablation is performed. There are manufacturers' protocols for each probe that differ slightly. And this is followed by bed rest for a few hours prior to discharge. The post-procedure course. After the ablation, it's normal to feel some flank soreness, which can usually be managed with Tylenol. It is normal to have a little bit of blood in the urine, especially if you're treating something that's a bit deeper into the kidney. It's fairly uncommon, but it can happen. Will usually resolve on its own. Some patients will experience something called post-ablation syndrome. This is characterized by a low-grade fever, so not high fevers, but low fevers, a bit of nausea, in addition to the soreness, and usually that'll resolve in a day or two. Since we're treating fairly small masses, these symptoms are usually fairly limited. At our center, we'll reassess patients usually in about a week, and then at that point schedule follow-up imaging. Our routine follow-up imaging usually consists of 2 to 3 CAT scans in the first year, followed by annual CAT scans to make sure there's no residual and no recurrence. It's not entirely clear how long that should last. It seems like most recurrences happen in the first 5 years. So those are the ones that are really important. How effective is radiofrequency ablation and cryoablation? They have been found fairly comparable to partial nephrectomy in large studies. There's no difference in cancer-specific 5-year survival for small masses, that's less than 4 centimeters. This is study number 6, which I have in the references, found that partial nephrectomy, RFA, and cryoablation were pretty close to 100% effective. It's very important to note this, that the comparisons are dependent on size and location. So if patients are chosen inappropriately for this technique, the results won't be as good. Some of the caveats are most studies are retrospective and will report slightly higher all-cause mortality, means dying from other causes other than kidney cancer. But most of them contain significant bias because they are retrospective, and generally sicker patients are sent to ablation preferentially. And this difference tends to disappear with something called propensity matching, where you match patients like for like for ablation and surgery. Complications. Major complication rates are less than 5%. I think some of the things that could happen, bleeding, which is typically self-limited, but may require an additional treatment, such as admission to the hospital, transfusion, or rarely an embolization, which is, again, a minimally invasive procedure where we direct a small catheter to one of the blood vessels in the kidney, whichever one is bleeding, and then block that blood vessel with either little coils or particles or some sort of slurry. I have not seen bleeding more than that. There used to be reports of more significant bleeding with cryoablation years ago, but it seems like the technology has matured in that time. There's always a small, anytime you puncture the body, there's always going to be a small risk of infection. Again, pretty rare, and typically will resolve on its own with some antibiotics. Injury to the bowel or gallbladder. This can be sometimes self-limited and can resolve on its own, particularly injury to the small bowel, but injury to the colon is likely to require surgery. This is why we're quite careful to keep as far away from the colon as possible. That's the reason for some of the additional measures taken to protect the colon by injecting gas to kind of separate it away from the kidney. Nerve injury can happen. It's typically self-limited, but people may have prolonged or permanent anesthesia or numbness of the anterior thigh on the same side. And that has to do with potential injury of the genitofemoral nerve, which runs on the muscle just behind the kidney. Skin injury, fairly uncommon. Typically self-limited, but you could have an injury from heating or cooling near the needle site, usually in very, very thin patients, or at grounding pad sites if one of them comes loose or more than one comes loose due to patient sweating or something along those lines, or lotions. It's one of the reasons we generally recommend patients don't put on lotion the night before the procedure to avoid that risk of the grounding pad coming off our way. There is a small chance of injuring the collecting system. It can be self-limited or could require additional treatments such as drainage catheters, which may be permanent or could lead to kidney loss. This is a reason we try to avoid treating tumors that are too deep into the kidney. Finally, very unusual complication would be something called a pneumothorax. If you treat a tumor that's very high up on the kidney and close to the lung, it is possible to cross a little bit of the lung and cause an air leak, which can collect in the surrounding chest cavity, push on the normal lung and make it hard for you to breathe. If untreated, it can be dangerous. At our center, we do a fair number of lung biopsies, and those patients not infrequently develop pneumothoraces, and we treat them on an outpatient basis with a small catheter, chest tube, which allows the air to escape. Once the hole is sealed in the lung, the catheter can usually come out, usually by the next day. I have not seen that personally, but it has been reported. Residual and recurrence. Residual and recurrence are slightly different things. Residual is tumor that's left over after the ablation. Recurrence is tumor coming back after a period when there was no tumor seen on imaging. A 5 millimeter margin around the mass will generally ensure complete ablation. At our center, residuals were identified in about 9% of patients, and 6% had local recurrence after an initial complete ablation, which is comparable to other centers. The primary factor in both was larger size of the initial tumor. And so when discussing the appropriateness of this treatment, this is the reason why tumor size is an important consideration. Recurrent and residual tumor, however, are typically identified on follow-up imaging. This is why we do it, and we do it sort of very consistently, as consistently as possible. At our center, all the patients who had persistent small volume disease all went on to have repeat ablation, and so the treatment was completed. It just took an additional session. Occasionally, a salvage nephrectomy may be needed. These were typically patients where the choice for ablation was sort of marginal and more done on the basis of concern for their fitness, medical fitness to get surgery, and most of those did well. Follow-up imaging is critical to detect recurrence, so it's best done at the where previous imaging is available for comparison. Early recurrence can be fairly subtle and difficult to tell apart from normal kidney tissue, which can be distorted by scarring from the ablation. It's also helpful to have some familiarity with what the kidney looks like after an ablation. We've had issues previously where radiology groups at centers that don't deal with ablation typically will sometimes say, oh, the tumor looks bigger, or they just don't know how to interpret it, and can provide sort of confusing information. Afterwards, we have to reread it at our center, and patients end up being relatively anxious following something like that. You also need a renal mass protocol, abdominal CT or MRI with contrast, and you're looking for an abnormal growing enhancing tissue near where the edge of the ablation was. Distant metastases can happen. It's really quite rare, but a CAT scan or an MRI will identify them. This is why we need to do a CAT scan or an MRI rather than something like ultrasound. Ultrasound is not quite as effective at detecting recurrences. These are some of my references, and I think that's all I've got. So I'll take questions now. Thank you.
Okay. First question is, why is RFA or cryoablation performed on small tumors only?
Good question. So there's a few different reasons. I think the biggest reason is it's very hard to dissect away tissues and separate tissues. So in surgery, when you do a partial nephrectomy, you can reflect away or push the colon out of the way and then remove the tumor. In our case, we can inject air or fluid, but the bigger the tumor gets, the higher the risk of injuring something nearby. So that's reason number one. The second, equally important, perhaps more important reason is there are physics limitations to ablation. The heating only, you're basically inserting a small needle. And so the amount of tissue that you can heat up at a certain distance from the tumor starts to drop off as the power of the distance squared, or cubed, I should say. And so it's just not physically possible unless you use an extremely large needle, which would risk bleeding. In the case of cryoablation, somewhat bigger tumors can be treated with multiple needles. Again, each needle you add adds a risk of injury. It's never been really a great technique for large tumors.
Mm-hmm.
Good. First, sorry, you caught me off guard there, and I want to say thank you so much. This has been a really interesting talk for our patients. We hear more and more about radiofrequency ablation and cryoablation in particular, and we don't have a lot of resources there, so we really appreciate you talking to us and enlightening us a little bit. We do have another question, and it's from Eve. And Eve asks, what can you tell us about using ablation for metastatic sites such as the liver, which are proving to be stubborn and not necessarily responding to systemic therapies?
So treatment of metastases is, metastatic disease is not all the same. There is fairly good data on the treatment of oligometastatic disease, slow-growing oligometastatic disease. What is that? It means a few, preferably one or maybe two sites of disease, small volume disease, in an accessible location that's not growing too quickly. So we've done that for metastases to the liver, to the lungs, that sort of thing has been done for bones. The concern with metastatic disease is if it can be a bit of whack-a-mole. So you destroy one tumor and it pops up somewhere else. If they're simultaneously, I was once referred a patient with, I think, 25 or 30 metastases to the liver, and it's just not feasible to treat that many spots. But if you have a single small spot on the liver, I think it's a fairly reasonable treatment. There are certain organs that are, this is less well established for, not really established. For example, if you have metastases to the pancreas, there's a concern that you could end up with pretty bad episode of pancreatitis. But liver and lung are relatively reasonable. There's also trade-offs with all of these. There are alternative therapies, so medical treatments can treat things that can't be seen or small deposits that don't show up on CAT. But it would be a reasonable treatment.
Okay, good. I don't think Mona asked this question. I apologize, Mona, if you did. What's the difference between RFA and SBRT? Just if you could briefly explain that for our audience.
Sure. So radiofrequency ablation is you put a needle into the tumor and either burn it or in the place of cryoablation, freeze it directly. It is very, very, very targeted, and the energy that is applied is either cooling or heating. SBRT is radiation therapy, so it's I forget the acronym at the moment, but basically you are focusing X-ray beams on a focus of tumor. I think the targeting with RFA is in certain ways a little bit easier. You can confirm your position with a CAT scan and lock your probe in place, and then burn a volume down to a few millimeters that you know where exactly your burn is going to end. With radiation therapy, that beam has got to traverse different parts of the patient, and the patient's usually breathing, so breathing motion will affect your targeting. Whereas for what I do, the probe is locked in place.
Okay. Mona, would you like to ask Yvonne's question from the audience?
Yes, because it ties in a little bit to what we're talking about. She's asking, do you do radiation treatment instead of ablation if the tumor is too large for ablation?
So even though I'm called a radiologist, I don't do any radiation treatments. That's another specialty called radiation oncology. So we treat tumors up to a certain size. Once they get larger, the discussion is usually between the surgeons, radiation oncologists, and medical oncology. I'm not sure if you have a radiation oncologist on the panel, but that decision is usually left to a fairly different specialty, and I don't know as much about their side of things.
Fair enough. We did have a talk last forum on SBRT, so I appreciate your answer, and thank you for clearing that up for us. We have one more question from a patient, and she had RFA previously, and I'm not going to go into personal details, but her question comes around that about 2 years after her RFA done, She had nausea quite seriously, I guess, when it was first done. It's now long gone, but her appetite never fully returned. Would this be a standard type of side effect?
I don't think so. The long-term sequelae are, the things that can be long-term sequelae would be an injury, and that would be numbness to the anterior thigh on that same, or possibly a skin injury. Nausea can have multiple, many causes, so it's extremely hard for me to attribute it to any particular thing, particularly RFA. I don't know of a clear mechanism of how that would cause nausea persistently. I don't know how that would connect.
So it's not necessarily tied to the RFA. It's maybe something that this patient should speak to her doctor about.
Yeah, as I said, there are many causes for nausea. Nausea is not something that we understand well. There are medications, medical conditions, and all sorts of issues that can cause nausea. So it's one of those things that actually is, in more general terms, and the rest of my practice, it's very hard to treat sometimes because we don't have a clear, good understanding of the sort of the biological basis of nausea.
Okay, good. Thank you. I think, Mona, you have one more and then we can call it a wrap.
Yeah. Can RFA or cryoablation be done on the same spot more than once if there is a progression?
Yes. In fact, this is why we do follow-up imaging. I tell patients that, I expect probably about a 90%. Depends on the size of the mass and the exact location, but on average, I would say I expect a 90% chance that it'll be gone after the first treatment. If it's sufficiently small, I would say 95 or sometimes even 100%. But we do surveillance to make sure that if it does come back, it's usually fairly easily visible on CT or MRI, and then we can repeat treatment. Usually when it comes back, it's fairly small, and treatment is relatively straightforward. This is looking for recurrence at the ablation site. If you're talking about a recurrence somewhere else, again, it goes back to the question of metastatic disease, and that's another discussion.
Okay, thank you. That's great information. I think we're going to wrap it up. If there's questions that weren't answered, as previously, we will do our best to find the answers. Maybe we could speak to Dr. Mironoff another time and privately, and maybe get a couple of answers that haven't been addressed today. So thank you so much for joining us. I really appreciate it, and I hope you enjoy the rest of your Sunday. And now we found you, we might come looking for you again.
Thank you for having me.
Okay, take care. Thank you.